Hi, well, good evening, everybody. Thank you for joining us today on our presentation here on how to gain independence with low vision rehabilitation. So in this picture that we have here, we're in a clinic room and I'm standing next to Nilima Tanna, who is our occupational therapist. So just a little bit about myself. I am the low vision optometrist. I am currently in clinic just Tuesdays and Thursdays, and I have no financial disclosures. One video that I would like to show you before we go ahead and get started on everything, this is actually on our website. And note that it does have an emphasis on strategies and not just on tools and devices. So if we can go ahead and play that, that would be awesome.
Have you heard of low vision? Low vision refers to a vision impairment such as partial sight or legal blindness. Unfortunately, it is not correctable by surgery, medication, contacts, or glasses. However, there are certain tools and strategies that help people with low vision maintain daily activities. For example, you can organize your refrigerator such that certain items are designated to specific sections, so it's easier to find what you're looking for because it's always in the same place. Additionally, certain lamps can help enhance contrast and control glare, making it easier to see. Luckily, low vision technologies are also smaller and more powerful than ever. For example, magnifiers can increase the size of objects and text. Electronic devices such as book readers, smartwatches, and GPS navigation use voice technology to read information out loud.
It's 6:30 p.m.
Also, computer software can be installed to enlarge and adjust everything on screen for comfort. If you like visiting museums, attending sporting events, or watching movies, don't worry. Telescope attachments can attach to glasses to help with distance vision. Our practice specializes in helping patients with low vision. If you or someone you know has a visual impairment that interferes with their everyday life, get in touch with us to talk about your options.
They are emphasizing strategies and tools. The tools and devices, there's training that goes on with that. And so they are emphasizing other things as well, maybe organizing the refrigerator, maybe using illumination, technology as well. So these are some of the things that I will talk about in just a little bit. Now that video was on our website, so if you do want to review it again, you're more than welcome to. Now, in terms of things that are difficult, now, if we can go back one slide, we talk about maintaining independence. That is the title of our presentation here. We think about maintaining independence. What can we do to enjoy life, our ability to enjoy life without being hindered or helped by others, right? And so a lot of that comes down to what can be difficult, what in our vision can be difficult. So now moving on to our next slide, things that can be difficult. It can include reading. So perhaps detailed private mailings, perhaps reading bills and paying bills. What about distance tasks? Watching TV or seeing things far away. What about moving around, mobility? So contrast is a big issue. There could be visual field loss. Curbs and steps are hard to maneuver. So I have a picture down here where, there's a lot of steps. Now, on one side, if it's too dim, it's very hard to see where each step is because it's gray on gray. And then when it's very bright, things get bleached out. So that's difficult to see as well. Now, on the other picture, I have, a tree coming, kind of leaning sideways in there. I took that picture on purpose because some individuals were concentrating so much on just not tripping on the sidewalks as they're lifted up there. However, as we're looking down, maybe we have a visual field issue that we're not seeing things maybe a little bit higher above, and then we run the risk of hitting our heads on things that are just jutting out. So different things to think about, and there are different strategies that we can work on too. Now, what about personal goals and hobbies, things that we really enjoy that are now difficult? I have examples here of something for just about every distance. So golf for distance, playing cards, that's more intermediate type of distance. And knitting, crafting, that's more near type of distance. So very, very different goals. And, it comes down to the individual. So when we talk about goals and independence, now we take a look and see, is it something work related? If it is, it might require more computer type of technology. Or is it something more for leisure? Maybe it's task specific as well. Maybe it's watching TV or reading or even recognizing faces. That can be very difficult. Now, as the visual acuity changes or if the visual field changes, there's different strategies that we might be employing too. There's different things that we can use to help. And what about glare? Now, there are some individuals that see actually very well on the chart, maybe 20/30, maybe 20/40, but glare can cause that visual acuity all of a sudden to become maybe 2100 or 2200. And so, what are things that we can do to help that? Maybe there are filters that we can use. And so, we're taking a look to see what are the goals, what are things that are difficult, what about school needs, and also what the expectations are for each patient. So, as we're moving on here, it's not about not a one size fits all. Unfortunately, there are no magic glasses. I wish there were, but there are no magic glasses and there are no magic drops either. However, there's a lot of technology nowadays and a lot of strategies as well. And it really comes down to working together as a team to really implement these strategies and training the individual to achieve their goals. And this is why Nalima, who's the occupational therapist, and I, we work as a team to help each patient. So at the end of my exam, I will refer the patient on to the vision occupational therapist to further work on the goals. And she will do her own evaluation and then work further with the patient on training and exploration and strategies as well. Now, for my portion, the low vision exam, we do a very functional evaluation. And I try to get the details and we try to see what exactly it is that's difficult for the patient. So here's an example. So I do a little bit of, I take a look at how the patient is reading. Now, this chart, if you notice, the first line is, black on white. That's very high contrast. And then the second line is more gray on white. And that goes all the way down. And that gives me an idea of how the patient does with their contrast ability. Now, I do take a look to see how far down each patient will go. And I do take a look to see, how they do with contrast. But I also take a look at a few other things, such as the reading speed. Is it very difficult to read something? Also, are there missed words or areas where it's very difficult to see? And sometimes patients might have to make up what they think the word is saying because they're missing parts of certain words. Are there areas where it's difficult in general? When it comes to contrast, sometimes if we're moving the chart a little bit or if we get closer to the light, it might be easier to see. I'm looking at that. But also we're taking a look to see if there's the ability to work with magnifiers. And maybe some individuals have hand tremors too. So maybe those individuals, there's other options too that we can look at as well. So when it comes to reading, there's other things we're going to be talking about. And so definitely different areas that might help. Magnifiers, so all different types. Now, in my picture over there, you can see that there's a magnifier with some lighting that always helps. There's dome magnifiers, which kind of dome up, but some of them do have some lighting and some don't. There's also video magnifiers, which is electronic type of magnifiers too. Lighting and illumination, that is so important. And some individuals, that's all it takes, almost all it takes. The magnification portion helps, but lighting is so important. And also we take a look to see, are there central blind spots? It's called central scotoma, but there could also be blurry areas. So this is where the occupational therapist will work with the patient to maybe train them with eccentric viewing, using the side vision to kind of look around that blind spot or that blurry area. We'll talk a little bit more about that later. Now, in terms of magnifiers, there's so many. And, I have no financial disclosure, so I will be showing you just pictures of a bunch of devices, but I don't particularly have a favorite, or I'm not really saying which one is best for each individual, but I just want to show you the differences here. On that first picture, you can see that there's different types of magnifiers. So some look bigger and some look smaller. And, the common understanding is, okay, if I can get one that covers my page, that would be great because everything will be magnified. But the bigger magnifiers actually are not as powerful. The really small ones are more powerful. So then everybody thinks, well, what if I get the smaller one and now I can see more because it's more magnified? But then that really restricts our field of view or the area that we're looking at, right? So instead of reading the full sentence, we might be reading parts of the sentence or maybe even word by word. So again, this comes down to, the patient's visual acuity and what their goals are. Maybe their goal is to read a price tag. Maybe their goal is to just spot read certain items. Maybe they want to see really small. Maybe they want to see, the medication labels on their prescription bottles. So it just really depends on the goal. And it also depends on our ability to use the magnifier, and that takes training as well. So we do have to find that sweet spot where everything comes into focus, and that takes some time to get used to things. And then after all that, maybe it's that central area, that central blind spot that comes into play, or our contrast loss that is difficult too. So maybe there's other options as well. So it's really not a one size fits all. And this is where more evaluation and exploration comes in. There's also magnifier apps on the iPhone. I know everybody just uses a cell phone these days. There are free apps on there. And so sometimes using something like that could be helpful as well. So more exploration. Now, let's talk a little bit about lighting. So I mentioned earlier that this is very important. In the clinic, we have 2 lamps, both of them are shown here. They have gooseneck because you can actually adjust where the lighting is focused, right? That's really important. So we have the floor lamp there, we have the table lamp there. And sometimes it's wise to do a color temperature, a light evaluation with a low vision OT. And so that's something that, I would refer as a recommendation to, and she'll discuss that with the individual to see if that's a good fit. Also, filter evaluations. So when I talked about glare earlier, different colors, different filters might help the individual. So this could be something that we would do, inside the exam room, but maybe in another session, maybe outside. So it would be depending on what the individual's using their vision for and where they're using it. So we talked briefly about central scotomas and how there could be, blurry areas or blind spots right in the middle of the vision. And this is a test that I try to do on most everybody that comes in, because we just don't know exactly where that blind spot is. And it could be different for everybody. Now, you can see that in the bottom picture, this is an example of one where the patient's blind spot is right there and it's more to the left. So these are things that we look at very carefully, because now it makes sense maybe why they're having trouble reading the first portion of a sentence. But then as we get to the end, it's a little easier. And maybe this is where we can employ some eccentric viewing, kind of using that side vision that's not affected to see things a little bit easier. And this is where that training comes in with the OT. And when we use eccentric viewing, this could then help with recognizing faces, features on faces. And so this is what we're going to do next, or certain strategies just are not working. It could very well be this centroscotoma or this blur and blind spot that's getting in the way. Now, in terms of video magnifiers, it's a very broad category. It's basically anything electronic that would magnify things. I have a bunch of examples here. Again, just pictures. There's a lot more devices out there. So these are just samples of things. But the picture on the right, those are examples of portable video magnifiers. So this you would just put right on top of something and it would magnify. Now, a lot of these video magnifiers, it does two things. You can control the magnification level. So you can make things even bigger than that or smaller than that. And you can change the contrast. So you can kind of invert the contrast. We'll call it reverse contrast. And so if you look at the two pictures on the left there, these two pictures, they're examples of tabletop CCTVs. So that just sits on the table itself. You can put your magazines or your documents underneath it, and it'll project right onto the screen up above. It's a pretty big screen. So you have a pretty good field of view, a pretty good area that you're looking at, and magnify things. So you can actually change the magnification. You can make it bigger or smaller. And you can even take a look at photographs. For example, that picture of the man there, you can actually crank it up a little bit and take a look at the features of his face. And if you look on the other side, you have a contrast. So that in that case, we're kind of inverting the contrast. So now instead of white or black on white, now we're using white on black. And in some cases, some individuals find this more helpful because it cuts down the glare. So it just really depends on the patient and what their preference is and what's going to be more helpful. Now, there are also goggles. Now, in that bottom left picture, that's me wearing one of the Idaptic. There's an i5 model there. Now, I took a picture of that because I wanted to show how small it is these days. I mean, it's actually smaller than the mask that I was wearing at the time. But goggles like that, it actually allows you to magnify things and see things far away. So then you can be looking at something, let's say, if you were shopping, something on the sign up above. Then if you were looking at what you were, picking up to buy and maybe the price tag. And so in that case, play with the contrast a little bit. And of course, that's very good technology and they've made it really light these days. And of course, this all takes training and then we'd have to see if this is a good fit for the goals that the individual has. Now, the next goggle that I have in the model next to me, that's an example of Envision AI. So using technology, that can actually call a friend or a family member if the patient was walking around and wearing the Envision AI goggles to then have the friend or family member tell them what exactly they're looking at. So pretty neat technology out there. Now, like I mentioned, this is good for adjustment of magnification and contrast. And some individuals use these for prolonged reading because now you don't have to just hold something in place for a long period of time and holding it in that good working distance. You're just putting it down on what you want to read, or if you put it underneath the CCTV, it's just right underneath there. So you can read for a long period of time. You can be looking at photos. Some people do their crafting underneath there. There's different features too. So, it could, besides, reading for the patient, so I can read it just through AI. There's also a camera that can be attached to it. So if an individual wanted to take it to school, for example, there's different models that are portable, then there could be a camera for looking at something far away, and then things are still magnified for things up close. So different features, different things that can happen. So definitely a lot to explore when it comes to technology and video magnifiers. Okay, so distance tests. Again, a lot of telescopes, some examples here, but distance tests like watching a TV. So in the first two pictures, I have examples of just telescopes that person would wear. It does jet out a little bit, but you could potentially focus it a little bit and allow you to see things far away. Now, the one next to it is a monocular. So it would only be used over one eye, but it could be just for spotting things, spotting a street sign, spotting something like a sign in a grocery store. And then, you know, just being able to kind of move around afterwards and kind of see where we're going. So those are options. Now, Max TV, that's the next one that I'm wearing there. That's actually designed more for watching TV. It just magnifies things just a little bit so it can bring things into focus. However, some people find it more helpful if they used it for facial recognition, details on someone's face if they're standing a little bit closer. So different uses for different goals, right? And then I mentioned sight scope because the next two pictures are of me wearing the sight scope. So the first picture, I have that in place, right? So when I'm ready to look at something, I just snap it in place and then I can see things kind of far away. But if I'm not using it, say I'm getting ready to just kind of move around, I could just kind of flip it up out of the way. So different types of telescopes for what we want to do with life, right? And so different goals and different purposes. Now, I mentioned Vision AI earlier. There's also the OrCam, which does something similar. Now, the OrCam, there's an attachment, it's a magnetic attachment that goes on top of glasses. And, if the individual was going to read something, you could hold it up in front of the OrCam and say, OrCam, read, whatever I'm holding up. And so basically it would read, or you can train OrCam to recognize people, specific people in the room. So just different examples here and there for distance tests. So moving on to the next slide. Oh, yes. So mobility. When it comes to maneuvering, there's orientation and mobility and cane training. And generally, there are specific instructors at the Braille Institute that will train the individuals. And what I'll do is make referrals to the Braille Institute location closest to the patient. And we can get that process started. And also guide dogs. Usually, they require that the individual be already familiar with the orientation, mobility, cane training. There's other technology to help with mobility. One that I have listed is the Sunu band, and that uses echolocation to detect objects that are waist level and above. So that could be helpful, to prevent hitting the head against, cabinets or branches when we're out and about. So that's just one example of that. Now, when it comes to driving, this is a very complicated type of goal, just because there's so many rules and regulations. And so this is really a whole lecture by itself. And a lot of times this really, I can do a whole full examination is really what's necessary. And then I will fill out a DL62 form, and there's bioptic telescopes as well, but this really depends on the level of vision and the patient's goals. Okay. Now, so when we're talking about my whole low vision exam, really, it's addressing how functional is the vision. But we talked about visual acuity, that number, be it 20/80 or 20/200, really, it doesn't tell us as much as if we have more information about contrast loss and maybe more about, the central scotoma, that central blind spot, or maybe even that, that glare that's really bothering the patient. So once we gather all this information, and my exams do take a little bit of time, but then I can maybe give a few sneak peeks on, if maybe some magnifiers might help, or telescopes might help, or CCTVs that are in my exam room. But those are really sneak peeks, because to really get a sense of how well the patient can do with all of this, we need training. We also need evaluation with the OT to see what the individual patient goals are and how we can really work together to, just help the patient, learn the strategies and train them with some of these devices, or if any of these devices are going to be helpful, or all of them. So really, low vision rehabilitation is really based on function. And so when I see patients, I really prefer that previous exam information from eye doctors are sent to me, so that we can take a look and see, if there's any changes in the vision, but also if, previous magnifiers and devices and glasses, what really helped and what doesn't. And then we can kind of build on from there. And I always send a summary with my exam findings to the referring doctor. And then at the end of my exam, I refer to the occupational therapist. And this is where we work as a team to really further explore the goals and what we can do to help each patient. And so when we talk about the occupational therapist, now I'm very fortunate to be able to work with Nilima, and she is so experienced. She has so many years of experience behind her. She's worked at the Braille Institute. She's worked at other low vision facilities. And so it is this collaboration that, I am fortunate to be a part of this low vision team. And so she's going to be talking next about what she does.
Hi, everyone. My name is Nilima, and I know it's a hard name, but I tell people, if you think of your knee, is the first part of my name, and Lima, like Lima, Peru. So my name is Nilima. I'm an occupational therapist that specializes in vision rehabilitation. I've been working in this field for, close to 30 years now. So that kind of tells you how old I am. But I really, really enjoy it. And the reason I enjoy it so much is because each and every one of you is so different. So it keeps my job interesting all the time. So a lot of times when people are told that you're going to be referred to occupational therapy for low vision, here are the 3 questions we get all the time. What is it? Do I really need it? And what should I expect from it? So I'm going to try and answer those questions. Occupational therapy, some of you may be familiar with it because you or somebody you know has received those services. It's a client-centered health profession, which is concerned with promoting health and well-being through occupation. And I had a patient once tell me, I don't need occupational therapy. I don't have an occupation. I'm retired. So when we say occupation, we mean your occupation in living, the meaningful activities that you want to do, that you need to do. And every day, right from the time you get up till the time you go to bed, we share some common occupations like eating, getting dressed, walking, or moving around. But then, as individuals, we each have certain occupations that are more meaningful to us. So the purpose of occupational therapy is to enhance or enable participation through the therapeutic use of daily activity. Occupational therapy for vision rehab. So I ask you, what is your occupation? What are the things that you struggle with on a day-to-day basis because of your vision? Whenever I see clients, they usually tell me, I want to see better. And then we have a discussion about what is better and what exactly do they want to get better at? What activities are hindered because of their vision impairment? And we talk about realistic goals. As most occupational therapists, I use a holistic approach when I work with patients. So the beauty of working as a team, and let me tell you, it's a blessing to be able to work with Dr. Lin, because as you just heard her, she does a fantastic job doing such an in-depth evaluation. And then my job is to build on that evaluation and really get into the details of things that are difficult for you. And I'm going to share how I gather information about your wants, needs, your struggles, your limitations, and analyze them so that we create a plan that's mutually acceptable for both of us, and then start treatment. Like Dr. Lin mentioned, we do collaborate a lot and have a great teamwork. She fills me in on all the information from her evaluation. And then as I start working with y'all or the patients that we see, we go back and forth so that at the end, the person who comes to see us meets their goals in a very efficient manner. The first visit, which would be the evaluation, is usually in the clinic. After that, the follow-ups are usually in your setting. And the reason for that is, yes, believe me, I get to come and work with you in your home so you don't have to worry about transportation. The reason for that is how many times people go somewhere to get a device or glasses, and then they go home and they don't work. I've been to multiple patient homes where there are tons of glasses and magnifiers that are just sitting around. The struggles that you encounter are in your home, so it just makes sense to work with you in your home setting so I can analyze how you do your activities. I get to analyze your environment and then guide you with recommendations. So I'm truly blessed that Gavin Herbert Eye Institute lets me work with patients in the home. I don't know of any other occupational therapist, honestly, in Orange County that gets to do that. So I'm very lucky. So like Dr. Lin mentioned, here are some of the common struggles with your occupations or your meaningful activities. And these are just general struggles. That doesn't mean everybody has difficulty with every activity, but difficulties with reading, like she mentioned, or recognizing faces, watching TV are very common. So are difficulties with small day-to-day activities, like putting toothpaste on your toothbrush, or unable to read back what you write, managing your bills, dropping pills, managing medications, using the phone. Glare can also be an issue, especially I think it's a very Southern California thing, because I talk to my other therapists in other parts of the country, and they're not as lucky as we are with sunshine and homes that have so many windows, but then that also gives a lot of glare inside the house. Navigation. Walking around can be difficult with people with certain diagnoses. Dr. Lin already mentioned driving. Sometimes it's extremely difficult to find things. And this is different than the difficulty finding things that we normally have. Like I have difficulty finding my keys, but that's because I never remember where I put them. This is difficulty finding things because of your vision impairment. Sometimes patients will come in and say they have difficulty with depth perception. And then as I talk to them, I realize that they're talking about difficulties coming down the steps, or seeing the curb cut out, or even pouring something, water in a cup. Sometimes I'll hear about difficulties with fluctuating vision. So what I would like to do, and this is probably something I really enjoy doing, is I like to figure out all the factors that are making things difficult, specific tasks that are difficult, that are important to you. But then I also want to be able to empower you with the education so that when we finish our sessions, you get the knowledge as to, and when you struggle, you can take a step back and say, why is this difficult for me? Could it be A, B, C, or D? And then what can I do about it? And this works especially for day-to-day tasks. So let's talk about reading, more from the occupational therapy hat on. Decreased visual field makes reading difficult. And so the picture on my right is how sometimes words look like for somebody who has macular degeneration. There are letters missing, or there might be words missing. But like Dr. Lin said, usually if it is because of scotoma interference, there's a pattern as to which words are missing. And my goal is to help identify the pattern. So I take the information from her central visual field test, and then I do other reading tests to figure out what the patterns are so we can do eccentric viewing training. A person who has peripheral field loss may see words like the ones on my left. They don't see all the words, and it's very common for individuals with peripheral field loss to miss the next line. So as they're reading, they lose their place quite a bit. Again, these are just general statements. Not everybody has the same issues, but this is for the purpose of education. Decreased resolution, your ability to see fine detail, can also make it difficult for you to be able to read. And in the picture on my left, there's a decreased resolution with a little bit of a blind spot on it, which kind of helps you understand when there are more than one factors, how things might look. As Dr. Lin mentioned, contrast is a huge thing. Sometimes people will say, I read so well in the doctor's office, but when I went home, I couldn't read my newspaper or my magazines or my bills. Sometimes it could also be because a contrast on those things is not very good. Newspapers are not very white, and the print is not dark enough. As you all know, light makes a big difference. My job is to help you identify what is the right kind of light for you. Placement of lighting is critical, and how to use the light appropriately for different tasks is also very critical. Dr. Lin talked about contrast, and on the right, I have an example of reverse contrast. When things are white on black or black on white, it's much easier to see. Size matters. You know, there's an assumption that bigger is always better, but that's not necessarily true sometimes. And we want to be able to figure out the optimal print size that works best for you. At the bottom, I have a little yellow square that's absolutely yellow, which makes it very difficult to read the word inside. I wanted to give you an impression as to how when there's too much glare, it's hard to see the words. And that applies quite a bit when people are on the computer, or they just have a bright light on what they're trying to read, but they're sitting in a room that's fairly dimly lit. Some of the other factors that I look at when I'm working on the goals are whether you want to access print, which means books, newspaper, mail, bills, or you want to be able to access technology, whether it's computer, tablet, cell phone, or if it's both. Like Dr. Lin mentioned, we want to kind of figure out if you want to go for short reading or long reading. And that helps us figure out what kind of devices might work for you. With aging come a lot of different issues. And so we want to be able to make sure that If there are other factors like physical challenges with arthritis or tremors, we keep that in the back of our mind as we are doing the evaluation. There are psychosocial factors, cognitive factors, and other health concerns which guide us in creating a treatment plan. Some of the things that I can help out with is the maximizing the use of your remaining vision. Like Dr. Lin mentioned, for people that have central visual field loss, eccentric viewing may be something that might work for you. If it's peripheral field loss, we may explore scanning training. We want to really identify and train you in the use of the optical devices that will work best for you. And if your goals are such that you might benefit from a different compensatory technique to access print, for example, like audiobooks, then that's what we'll discuss. Everybody is different, and we need to take into consideration all the factors. I want to be able to work with you to apply the principles of lighting, contrast, and glare in your day-to-day tasks. So if you're writing something and if it's difficult for you to read, it might also be because reading is difficult, but maybe it's just difficult because you're using a ballpoint pen, which is not dark enough. Toothpaste and toothbrush, if you're trying to use a white toothpaste on a white toothbrush, there's no contrast. So how can we change that? And how can we use our best vision to be able to apply the toothpaste on the toothbrush? We look at some non-optical aids sometimes. So it's hard for you to see the buttons on your microwave. Can we mark them? Can we look at remote controls that are alternate remote controls that will allow you to access your TV a lot easier? A lot of people are using cell phones, and it's difficult and a struggle to use them because of the vision impairment. So we want to be able to work with you on that. I do complete a lighting assessment. I build on Dr. Lin's glare filter assessment, provide you with a lot of resources and referrals as needed for services in the community. So whether it's Braille Institute or Dale McIntosh or books on tape services from the Library of Congress. I have worked with people with vision impairment for many, many years now. We don't realize how much we rely on our vision for everyday tasks until the vision starts failing. Research shows that there's a high percentage of individuals that have depression with vision loss. Coping with vision loss, it may require professional help. There are support groups through Braille Institute that might help you. I'll urge people to be very proactive in your education about your vision. So for example, if you have glaucoma and the doctor is doing a visual field test, please make sure that they explain to you what that means, how much usable vision you have, and that helps us in the rehab process to build strategies. Be compliant with your medications, stay engaged, and seek vision rehabilitation. You'll be surprised at how helpful it can be. We thank you for listening to us today.